This is now picking up. I'm liking it. I'm loving it actually.
Yeah, and then I think the theme, the quality of the subject is there. Because I think it's going. I'm the only one who said he wasn't a gangster. He was an actor. And he got killed by gangsters. That's why nobody said anything. Oh, this is gonna be nice. Hey guys, how's it going?
This is a very original take on Tupac was an actor.
I know. I've thought that. Now we're live right now, right? Um,
Yes, we are
I
live right now. You can start with the topic and we can continue this discussion later when we're doing the narcissism thing. Uh,
yes, this is good. Well,
okay,
stay on. I think it's very interesting to talk to you on in these circumstances. Very interesting. So today, so
sure,
we're
dog.
gonna.
But this is a medical lecture time, so
Okay, yeah. So
I
you
will
go ahead
not
and
intervene.
I'll go ahead and start with the medical lecture time and stuff, and then I'm gonna
Okay,
go ahead
bye.
and start sending out the invites and stuff like that. Okay, let me see. Okay, let me send. I'm gonna send the link to some of my students. You can join via audio. You don't have to join via video, but audio. But I'll be interested in see some of your discussions about the basal ganglia. We're gonna go through all the different mood disorders in the basal ganglia, so you can recognize those. And because we went over the networking, the receptors, the pathways, the functionality, you can go back and review those videos to refresh yourself. But we're going to go and look at the movement disorder. So we just look at the. So when you see someone movement, hopefully you can sort of look at them and sort of look at the track their basal ganglia and see what's going on. Okay, let me see. Okay, I'm going to send this out. Okay, who am I going to send this to? Okay, we got that. Hey guys, come on in. I'm gonna give you guys a chance to come on in before we get started. We'll get started when we talk about the basal ganglia. Okay, guys, we're gonna wait till a few more people come in before we get started. We're gonna start on talking about the basal ganglia. It's going to be 20 minutes. That's it. I'm not gonna take too long for this. Very interesting series on the basal ganglia, and I think after we finish looking at this, when we select the medications, I think you get a very good idea of what medications to use and how to treat this. Okay, so let's look here. Let me look here. Okay, here. I started using the AI search engine, and I started looking and comparing this sort of to the textbook and see, is there anything important that I'm mixing from the textbook that I'm getting here from the AI? And I think the AI gives you a very good conceptual understanding of what's happening. I think the conceptual understanding may be easier to grasp from looking at AI than actually reading it in a text. Reading textbooks, you have to learn to become mature to read textbooks, because they use such structured language and things like that. We don't really speak like that. And we don't even think like that. So hopefully with this linguistic language model, hopefully, it presents the information in a more reasonable and down-to-earth fashion. Um, and I believe that because it serves as an aggregator of the content, then I'm sure it's looking at the credible sites, maybe like mail sites and things like that, to extract this information. So let me just show an overview of the basal ganglia first. Okay, let me try and do like images. Here's the brain, here's the front, here's the back, and here is the collection of subthalamic nuclei here. And parts of it here, you see parts of it here. Look how it's depicted here, Look how it's depicted here. It's the basal ganglia, right? Depicted here. Now this is front, this is a sideways view. Here's the front, here's the back. Here's a view, a coronal view when you a slice through here. And this is, you're looking from the front backwards. And this is sort of how the morphology, how it looks forward and backwards. Remember, we went through these pathways here, the direct, indirect pathways, things like that. Okay. Okay, here's the striatum. Okay, the D1 receptor, D2 receptors. This is going through a little bit something else a little bit different, but remember the direct, indirect, and the hyperdirect pathways, that these pathways have been preserved throughout all mammals. And it's very stable pathways. So meaning it hasn't changed much in evolution either. Okay, so we have this, the basal ganglia. So that's what we're talking about there. Let's go through here. Let's go through the basal ganglia, the different movement disorders that are associated with basal ganglia dysfunction. So basal ganglia movement disorders arise from dysfunction within the basal ganglia, a group of brain structures crucial for initiating and controlling movement. It allows you to do this. Look how much coordination something like this would have to happen. It's a lever pulley system, extenders, contractors, and things like this. So one is activated. These are contracting, while these are inhibiting. These are contracting, while these are relaxing. It has to do that. Look at this. Look at this. Look. I don't want to do YouTube. So look at that. This is impressive. Let me try to extend my P. This basal ganglia has very fine control over all these. Look how you like senior. Look at this. Look at these. Look at these. I mean, look. I can do this. Look, this. You take this stuff for granted. Look at this. Look. Yeah. Take all that for granted with your basal ganglia. Everything working well. Can you imagine dancing? Man, that's it. People who are graceful, you assume that all this stuff is functioning well. With graceful people who are cumbersome, yeah, you kind of avoid them. Something wrong with that basal ganglia. You don't know where it's at, but something's wrong. But somebody's dancing really good, someone who's smooth and graceful and things like that, you have a tendency to get more relaxed and admire those people. That's the basal ganglia. These disorders can manifest as problems with initiating movement, sustaining movements, or stopping. Right? Initiating, sustaining, stopping. That makes sense. Also involve voluntary movements or tremors, involuntary movements or tremors. The disorders are broadly categorized into those that can reduce movement, hypokinetic, and those that can cause the excessive or abnormal movements, hyperkinetic. This linguistic language model is amazing because these AI descriptions of these very complex brain structures, they explain in everyday terms, and it seems so simple. So in this case, basal ganglia dysfunction usually are categorized in two categories: things that are moving slow and things that are moving too fast, right? Hypokinetic, psychomotor slowing, psychomotor retardation, and if it gets worse, catatonia. Hyperkinetic, restlessness, increased psychomotor activity, increased agitation, increased combativeness and aggressiveness, frank agitation, psychotic agitation, right? Too much glutamate. Okay, So just look at just the general problems that the diagnosis associated with the movement disorders. Okay, look at the hypokinetic versus the hyperkinetic, right? Let me look at this motor circuit real quick. The basal ganglia are part of a large motor circuit that involves the cerebral cortex, right? The cerebral cortex, you have to think. The thalamus, you have to make sense of it, and other brain regions. Okay, and remember, they go down to the striatum, which is a part of the basal ganglia that contains the direct and indirect pathway. Disruptions in this disruptions in this circuit, particularly within the basal ganglia, can lead to movement disorders. Here are examples. We went through Parkinson's disease. Muhammad Ali, the punch is inflammation. They build up the tau particles, the intraclusion and intracellular inclusion bodies, build up, interfere with the internal functioning of the cell eventually dies. The death of the brain cells, and the tracts in the basal ganglia lead to psychomotor slowing retardation, because ultimately the brain cells themselves produce dopamine, and because you're having a death of the dopamine cells, then that means that the total amount of dopamine you're producing is if you're destroying the cells that produce dopamine, then the overall production of dopamine is going to be decreased if you're destroying the cells. And so over time, you see the decrease the hypoactivity associated with Parkinson's disease, and so you so Muhammad Ali slow down over a period of time. There it is, the bradykinesia, right? And postural instability, if the contraction relaxation mechanism, the pulley mechanism, is not following, how can you stand up like a stalk? Then you're going to fall to a certain side, because their skeletal muscle, your axial skeletal muscle, is going to be able to hold your spine up, fall over. So remember Parkinson's disease, and remember carbidopa, levodopa, and everything. We give that, and increases the production and increases the production and availability of dopamine. All right, so try to get more dopamine into that system. All right. Huntington's disease. Remember, we went through Huntington's disease. On that. Remember that CAG repeat. Remember that I think it's a TTA gene or something like that on chromosome 4, and it disabled the direct pathway. Remember, the cortex sends the pathways down to the striatum. That's the cortical striatum. Within the striatum, you have two pathways, the direct loop and the indirect loop. And then I don't know if the hyperdirect loop is there, but that direct loop is an autosomal dominant CAG repeat pair that's malfunctions. And so the protein strands don't develop normally. They don't fit inside of this factory. So they have to discard it and put all the debris to the side, and that's probably the process. So here, Huntington's disease, that indirect pathway, and so you get the lack of inhibition. So you get uncontrolled rapid movement seen in Huntington's disease. And remember, this is genetically dominant, so we primarily treat the symptoms. Okay, here's another one, dystonia, right? If the muscle is not relaxing, chorea, if it won't stop moving, hemiballism, if you're swinging that thing, right? If it's stiff, if it's stiff like this, a dystonia, or if it's moving like this is chorea, or if it's I mean, I don't know how many times I've been hit in the face by patients with Parkinson's disease, because they'll grab you. And stuff. Because of these things, they'll grab you and then they can't let go. This is a serious issue in some of the nursing homes, because many people are just fragile. And if you have a patient with these movement disorders, they can clamp down pretty quickly, and they can injure, punch or injure people. So it's important for you as their physician to really understand the potential risk that they can put other people in around them. And you just don't want your patient in that situation ever. I mean, you want to have them under very good control, so they don't have any of those interpersonal difficulties connected to their illness. Because sometimes people get personally blamed for the illnesses they have, and they don't even understand what's going on in many cases. So it's very important that you make sure your You address these in these patients. Okay, dystonia, characterized by a sustained or repetitive muscle contraction. Sustained or repetitive muscle contractions causing twisting and abnormal postures. You know, I usually see the sustained, the slow stuff, maybe 90% of the time. I don't see the repetitive. Maybe you see, I don't know. Maybe it's that. Career, rapid, jerky, involuntary movements that flow from one muscle to another. Rapid, jerky, involuntary. Okay. Hemiballism, a rare condition called violent involuntary flinging movements on one side of the body. Great. Okay, so basically these are the four types of disorders you can get. Let me go back here and read how they're classified now. Okay, the hypokinetic disorders. These disorders are characterized by a reduction in movement, often described as slow or rigid. Parkinson's disease is the most well-known example, okay, of a hypokinetic disorder associated with basal ganglia dysfunction. Yeah, because it destroyed it destroyed many of the dopaminergic brain cells in the substantia nigra. And when you look at the cross section on the autopsy specimen, then the methylene blue stain in that area doesn't pick up as much, and so you have decreased staining in the substantia nigra, and that's the evidence that those brain cells are actually dead, have died, and that's the mechanism that's creating the whole problem. Okay, hyperkinetic disorders. These disorders involve excessive involuntary movement. Examples: Huntington disease, hemiballism, chorea, and dystonia. Motor circuits. The basal ganglia are a part of a large motor circuit that involves the cerebral cortex and hypothalamus of brain wave. Disruption in the circuit, particularly the basal ganglia disorder. Okay. Now let me causes. Okay, genetic factors. Huntington disease, right? Look at this, brain injury. We went through this with Muhammad Ali and sort of emphasized the 26,000 punches to the head. Inflammation, I think that was the mechanism. So here, brain injury, trauma, inflammation. Again, stroke, destroy brain tissue, debris. The immune system would have to clean it up. It comes in, increases the porous blood-brain barrier. All the substances come in and it interferes with the functionality of the network at that point. So that's the mechanism of stroke, and that chronic inflammation is just there it could be there all for years. Okay, neurodegenerative disease, Parkinson's, may involve the progressive loss of specific brain cells. Remember, the process of pure Parkinson's disease is the intra-inclusion bodies that build up on the inside. And so that's thought to be the mechanism of action. However, when you stain for tau proteins, those proteins throughout the entire brain, a lot of regions, not only the substantia nigra highlights when you search for it, these plaques are actually throughout the brain. And they said, well, hey, we thought that the amyloid plaques were just pathognomonic for these, and we felt that they were located in the basal ganglia. We felt that these were the cause. Well, why are these everywhere? So right now, they're not sure. I can't remember off the top of my mind the switching mechanism that allows the vulnerability in that location. You know, I may have to go back and review this, but if I can recall, the damage to the brain cells can occur on a regular basis due to these depositions. However, the location of the damage, if it hits a nerve root, yep, if I can recall, that's what it was, is that there seems to be an anatomical location that has a lot of traffic in it. And if you hit damage to the tau problem area, it starts to impact a lot of the circuitry right there. Whereas other tau products that's distributed throughout other locations, when they start to cause damage to those brain cells, they may not be connected to all these essential structures. And so that's why the substantia nigra and the vulnerability, that's the reason why that probably leads to the process. And then I want to have one of my students at least look that up. If I'm wrong, let me know. if I because I'm doing all this stuff from memory, I gotta look at this stuff. I gotta go back and look at my art journals and stuff like that. So what about students? If I'm wrong, then just tell me I'm wrong. Okay, let me just see who I have here. Okay, let me see. Anyone want to speak up today? Let me see. Jennifer, how you doing? You doing okay? You can just keep the audio on. It's fine. Any questions?
I have any questions?
Great. Let me see. Okay, so how you doing today, Jennifer?
I'm doing fine.
What you up to today? How you feeling?
I'm feeling fine.
You feeling fine?
Yes.
That's good. That's good. Well, feel free to if any comments, feel free to let me know. Okay. Hey, me and Jennifer working together. It's a pleasure working with you, and I think we're going to do a lot of good work together, Jennifer.
Yes, I believe so.
Yeah, I think we're going to really provide some really good care for our patients. I think our patients are going to really be proud of what we're doing.
Yes.
Trying to make a lot of changes here for our patients. They need it. Okay, so let me see. Let me go to the question section here. Okay. Hey, Moeen, are tremors always a sign of basal ganglia dysfunction, issues? I believe so. No, twitches. Twitches are at the periphery, but these major ones, yes. Next, what role does dopamine play in these disorders? Dopamine is the main neurotransmitter that's responsible for all of these movements and stuff. If dopamine isn't there, you don't move. Patients who use cocaine typically have produce an excessive amount of dopamine that causes activation of a network called the mesolimbic network. That mesolimbic network is the network that's responsible for intoxication. So when dopamine levels are high, you sort of have the dopamine intoxication that what cocaine does. But cocaine, what it does is it uses all the dopamine up. And then at some point, the person has a decreased amount of dopamine and all the networks are hypoactive. And then that's when they're fatigued, withdrawn, fatigued, tired, and exhausted. You got to give them a day or so to sort of recover from that because it's too much. Okay, so we're at the 22-minute mark. I only wanted to keep these lectures at 20 minutes. So if anyone, any questions? And did anyone have any other questions for me? Nassar, any questions, buddy?
No, thank you, doctor.
Yeah, how you doing? No comments?
There's a lot of questions. It's just taking the information in and reviewing it.
You know what? It's a lot of questions at one time. It's a lot of content at one time and stuff. That's why we keep it to 20 minutes and stuff.
Yeah. Thank you so much, doctor.
Great. Okay, so I'm gonna go ahead and end this, and then we're gonna pick it up tomorrow. I don't think I can do anything else on the basal ganglia. I'm trying to go through each section all the way through. I'm going to pick up, we went through that mesocortical pathway for schizophrenia and autism, the mesolimbic pathway to substance abuse, learning and motivation, and the basal ganglia for all the movement disorders and things like that. So I think we're making some pretty good progress. And so I'm going to look at the other issues like that and see if I can present it tomorrow. So I'm going to pick a topic for tomorrow.
Okay.
Okay, guys, I'll see you guys tomorrow. It's been a pleasure. And on my next show is going to be, what is this going to be about? Tupac.
Okay.
Yeah, Tupac was an actor. He wasn't a gangster. He was an actor. It'll be interesting. Okay. I'll talk to you guys later. Read out. Take care, guys. You have a nice day, okay?